I'm delighted to be briefly welcoming all of you from, I think, at least 5 provinces today. We've had record attendance for this webinar, well over 100 registrants, so we're very excited about that and to be sharing this information with you. I'd like to start off by acknowledging that Mental Health Research Canada's office is located in Toronto in the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And while I have colleagues on the line that are working from their home offices and also joining from other traditional territories, wanted to just comment that we're all most grateful and respectful of the important history of the land. So as I mentioned, we're very excited to be welcoming you here today to our Spotlight on Research webinar series. Mental Health Research Canada has many important partnerships across the country that enables us to support leading research. And this webinar series is our commitment to helping to share and raise awareness about that research. Our next webinar, while I have your attention at the beginning of the webinar, I just want to mention that our next webinar is coming up. Apologies, all of your screens are covering it on Thursday, March 31st at 1 p.m. Eastern Standard Time. So I hope that some of you in the audience will join us for that as well. It's also focused on COVID. And look forward to hopefully welcoming you at that event as well. I would like to acknowledge also my colleague Sarah Murphy, who's our coordinator of grants and studentships, and she does an outstanding job throughout all of her work in coordinating and managing everything to do with MHRC's grants and studentships, and she's instrumental, of course, in planning today's event. So thank you, Sarah. She'll be helping out through the event as well. Very, very pleased to be introducing Patrick Ognicon. Hope I pronounced that correctly this time, Patrick, CEO at Saskatchewan Health Research Foundation. We've been partnering with Saskatchewan Health Research Foundation now on a number of initiatives and have already committed to partnering with them next fiscal year as well. So we're very excited. And at MHRC, we don't do anything alone. Everything we do is through collaboration. And it's very important to us to honor local priorities so that we can add value and support initiatives deemed important by the organizations and researchers and individuals that know best what a particular province or region is in need of. And that's our collaborative stance and our approach to all of our partnerships. So without further ado, I'd like to thank Patrick and his team. It's a pleasure working with all of you. And Patrick's going to say a few words and introduce our researchers for today. So thank you for being here, Patrick. I know you've had a very busy week.
Thank you very much, Akila, and team here. Just so you know that SHRF is the research agency that funds and facilitates and supports health research in Saskatchewan, and we're very proud to co-fund and partner with MHRC on this initiative and others, and very much looking forward to moving forward and expanding our partnership in the years forward. I'd like to introduce the team working on the CSRS project. And first we have Vaidehi Pisolkar, is currently a PhD student in the Department of Community Health and Epidemiology at the University of Saskatchewan. Danielle, I think you were here. Adeyinka is currently a postdoctoral fellowship with the Saskatchewan Population Health and Evaluation Research Unit, otherwise known as FIRU, at the University of Saskatchewan. Natalie, Kallio, is research officer with the Saskatchewan Population Health and Evaluation Unit at the U of S. Dr. Tamara Hinz is child and adolescent psychiatrist with the Saskatchewan Health Authority and assistant professor in the College of Medicine at the University of Saskatchewan. In addition to this, I know she's very busy with clinical and academic roles, but she's also a passionate advocate for youth and mental health struggles and other marginalized populations. So thank you for taking the time out of your schedule to be here with us, Tamara. And lastly, but not least, Dr. Nazeem Muhajarine is a professor in community health and epidemiology at the University of Saskatchewan and the lead of public health, health systems, and social policy at the Coronavirus Variants Rapid Response Network. And I'm not going to try the acronym on that one. He's also director of Sphero at the U of S, and if I can say, not necessarily a former, but he is an Achievement Award winner for a SCHRF's Achievement Award winner from a few years ago for all of his work that he does for Saskatchewan people and Saskatchewan research and health research in particular. So thank you very much for that, Nazim, and I'll hand it over to you and the team.
Can people see my slides, my screen, and can people hear me okay? Well, good afternoon, everyone. Patrick, thank you very much for that very generous introduction of not only me, but also the whole team who is present here. And also, before that, Akila, thank you very much for introduction and inviting us to present our research today. Ever since we started to work with Mental Health Research Canada, I believe it was end of 2020, and certainly by early 2021, we have really appreciated and enjoyed really working with your team, Akila, and we hope to continue that in the coming months and years. I'll do the presentation mainly, and I'll hand over at the end to my colleague, Dr. Hinz, to offer some perspective from a clinical point of view, and then there will hopefully be some time for questions as well. As questions come to your mind, do write them in the chat box and so on, so that we can take them up when the time comes for them. We want to start with acknowledging where we are joining from. We are joining you today from the Treaty 6 territory and the homeland of Métis, and we are dedicated to ensuring that the spirit of reconciliation and Treaty 6 are honored and respected. Personally, I acknowledge I'm a newcomer to these lands on which I arrived 30 years ago from land in South Asia, Sri Lanka specifically, and immediately made to feel welcomed in this province of Saskatchewan, where I made a home. I pay my respect to our Indigenous brothers and sisters. We want to begin with a little bit of a context for this mental health in children and youth and families research that we began in 2021, late winter, early spring. Because context, I think, is very important, and particularly during COVID-19. This slide shows how Saskatchewan fared in terms of COVID-19, specifically incident rates and case rates since the beginning of the pandemic in 2020. In the y-axis here, we have new cases, average over 7 days per 100,000 population. You see two incidence curves here. In red, you see children and youth 0 to 19 years of age, and in blue, you see all ages. On these curves, we have indicated major milestones, specifically reopening stages, an announcement of vaccinations right here, rollout of vaccination rollouts for adults and kids. You see clearly the 4 waves in Saskatchewan, and the heights or the intensity of those waves in relation to each other. So I'm not going to say anything more, but just to point out that in the 4th wave, which was in the fall of 2021, September, October, the case rates, incidence rates for children 0 to 19 was higher, than that for the rest of the age groups in Saskatchewan. I think that's an important observation, and we just need to keep that in mind. A little bit more context again, this slide shows the key milestones in relation to COVID, kids, and schools in Saskatchewan. We are talking about kids after all. I will not spend too much time here, but suffice to say there are two key points to mention here. After the initial closure of schools and move to online learning, schools in Saskatchewan opened in September 2020 and again this past fall, September 2021, with one of the least government mandated public health countermeasures anywhere in Canada. For example, mandatory masking was not in place for schools when they reopened in the fall in 2020 and again in 2021. Although it did go into effect, it was introduced after the reopening, after September. While there was a school reopening plan in September 2020, each school division was left to implement it in ways that they saw fit. In September 2021, no government introduced back-to-school plans were in place. Each school division, once again, was left to do what they saw fit. So here we now show the full complement of the studies we are conducting on mental health experience of kids and families during COVID in Saskatchewan. We affectionately call these our See Us, Hear Us studies. We are collecting both quantitative and qualitative data, and we see these studies as complementing each other rather than they are standalone or independent of each other. Our focus is on kids 8 to 18 years of age, living in families. We successfully recruited 510 child and parent dyads over 5 months, March to July in 2021. The method of recruitment was mainly through schools. We contacted all school divisions, public, Catholic, independent schools, First Nations administered schools. We also recruited from a community online panel. We partnered with Canadian Hub for Applied Social Research, CHASER for short, specifically with their full survey research lab here situated here in University of Saskatchewan. Participants completed online surveys, separate questionnaires for the youngest, which is 8 to 11, middle age, 12 to middle of that group, 12 to 15, and the oldest of the teens, 16 to 18, and a parent. Paper-based surveys were available, as were in French. So some data now. We are reporting results only from our kids survey today. In terms of who we recruited, we have all three age groups, the youngest, the middle group, and older teens well represented here on the left panel on the screen. We have slightly more who self-identified as boys, 52%. And importantly, about 3.5% who identified as other than girl or boy. In terms of geography, urban regions, Saskatoon and Regina, and mid-sized towns and rural regions were all well represented. 1 out of 4 participants self-declared that their ethnicity is a group other than white. And you see this in the pie chart on the right panel. Those who said they were indigenous were 15%, which is close but slightly under to their share of the population in Saskatchewan. Black or visible minorities were proportionately represented in our sample. However, our sample skewed to those from families with relatively higher income. About 50% of the sample were on the bottom half of the family income threshold we established at 100,000 Canadian dollars, given our data on family income. So this is the threshold we put for less than 100,000, above 100,000. Less than 100,000, there are 50% of the sample, fell into that group. 24% of participants didn't indicate their family income level, and this is not unusual to see in surveys of this sort. We labeled them as missing data for income, and we kept them in the analysis, so we are not losing those cases. The outcomes we modeled were three types. A point-in-time prevalence, meaning in last 7 days, whether they had experienced depression, anxiety, quality of life, and emotional dysregulation. These were measured using standardized, previously validated tools in other populations. Second, we modeled two outcomes that indicated the global impact of COVID, meaning since the pandemic began, specifically on overall mental health, the change of mental health prior to or since COVID-19 on mental health, and overall changes to life due to COVID-19. Third, we measured and modeled help and service-seeking behavior for mental health as well. So we see 7 outcomes listed here on this slide. This is a slide that shows all of the covariates or other independent variables that we model in our modeling regressions, and socio-demographic variables, behavior variables, particularly sleep, physical activity, and screen time, and what we label as contributing variables, mode of learning. So this is in-person at school learning, or at home learning, online, or some sort of a hybrid between the two, and help-seeking behavior, needing help but not getting it, needing help and getting that help, and not needing help during this COVID-19. So now we come to some prevalence estimates here. These are point-in-time prevalence for the 4 outcomes. The blue bands represent low or positive outcomes, and red bars represent high, moderate, or negative outcomes for each of these 4. We are a bit surprised that only about 1 in 10 indicated that they experienced moderate to high depression or anxiety. Emotional dysregulation was higher, 1 in 4 indicating this outcome. That is the third set of bars from the top. And 1 in 3 indicated that their quality of life either as low or moderate. That is the bottom set of bars. The global impact on mental health and life changes. These 38% said that since the pandemic began, the overall mental health has been worse, and 22% said a lot of fluctuations, and 59% said that the pandemic has caused more negative changes, and only 16% were more positive changes. This last outcome, help service-seeking behavior, is important. 1 out of 4 kids said they needed mental health services or support. Of these, a slightly higher proportion were getting the help they need versus they did not. So about 13% were getting the help they need, 11% were not getting the help that they needed during pandemic. This is a bit of a busy slide, but I will try to unpack this for you. We had 7 outcomes, lot of data, a lot of rich data, and this is one way that we want to simplify in terms of reporting. So a quick orientation to the slide. First, we have summarized results from 7 models. One multiple regression model per outcome. The models according to the outcome are shown at the top and in the columns. Those global change outcomes since the pandemic began, that overall mental health, life changes were modeled as multinomial regression models, meaning there are multiple outcome categories compared to a reference category. So that is why you see more than 7 columns here. 7 outcomes, but some outcomes had more than 2 variables to model. So that's why you see more than 7 outcomes. On the left margin here, we list the significant variables, only the statistically significant variables that are associated with the outcomes, grouped into socio-demographic on the top here, in the middle, behavior, and help seeking categories right at the bottom. The cells that are filled in red are associated with increased risk. Odds ratios greater than 1. Those in green are associated with lowered risk. Odds ratio less than 1. The key takeaway, so this is what I want to come to quickly here. The key takeaway here from the main effects results are that point-in-time outcomes and the global change outcomes are both associated significantly with age, with gender, with minority status, family income, number of people at home, screen time, and sleep. Some of the significant variables are not surprising. So for example, age, gender, income is not a surprise that they will be associated with mental health outcomes. But it is noteworthy that we found such variables as minority status, BIPOC, Black, Indigenous, people of color, number of people at home, screen time, sleep health significantly associated with several of the mental health outcomes. We will come back to this in our wrap-up. Also, I want to point out that some of the odds ratios we see here, the measures of strength of association, as well as the direction of the association are very high. So example for BIPOC here, the third row from the top versus white, the odds ratios are 28 times higher risk of high anxiety for those kids who are of minority status compared to those who are white. So, certainly for the help-seeking behaviors as well, on the bottom two rows to the left of that matrix. This shows a summary of significant interaction effects. So we didn't just stop at modeling only the main effects. We are interested in looking at how some variables might exacerbate or buffer the effect of independent variables on outcome. We focus our investigation of interaction effects to equity-seeking groups and to age and gender. So we didn't look at all the interactions that are possible in this data. Again, those groups that are equity-seeking and, of course, age and gender. The reason that we want to understand interaction effects are because it adds a layer of depth to our findings, and also, practically speaking, it can direct us to which groups in our population need more care and attention. So to look at one example of interaction effect in this table, take the second row from the top. So that's the one that you see, again, second row from the top, girl respondents and immigrant parent. As shown, the girls compared to boys are significantly less likely to report high anxiety or emotional dysregulation if they are in a family with at least one parent born outside of Canada. So they are the minority, status. Same type of mitigating effects for the outcome, life changes since the pandemic was seen as well. Girls from immigrant families are more likely to report the changes to their lives since the pandemic as positive, and conversely, less likely to report that the changes were negative. And again, we'll come back to that in our summary as well. There were more than half a dozen interactions that we found, but we are not reporting them all here in the interest of time. But we are going to be looking at, just as an illustration, two examples of interaction effects. This slide shows how ethnicity either buffers or exacerbates the effect of gender on high anxiety. We plot the probability of high anxiety for girls and boys. You see two lines here. The blue line shows the effect of BIPOC or minority girls and boys, and the red line for white. The non-parallel lines here show that for minority boys, the probability of high anxiety is greater compared to that of white boys, and that you see on the right end of this, the distance, the gap between these two points. Again, this is for minority boys. This line is for white respondents who are boys. This is an interesting interaction effect, how ethnicity moderates the effect of family income on health-seeking outcome. Specifically here, needing and getting help and services for mental health. Respondents with family income in the lower half of the sample were more likely to get help if their parents were Canadian-born. And that you see in this end of the on the x-axis, compared to parents born outside of Canada. For those for whom we didn't have family income and had a parent born outside of Canada were less likely to get the help they needed compared to their Canadian-born counterparts. So again, we see that for those who didn't report income are more likely to resemble those who reported income in the lower half of the scale. You see this inverted V-shaped red dash line that represents the respondents who had a parent not born in Canada, at least one parent. So it's time to sort of wrap up here and share with you some key takeaways from our analysis to date. Point number one, we present the point-in-time prevalence of anxiety, depression, emotional dysregulation, and quality of life, all outcomes measured using standardized scales. We have learned that these outcomes are very context and time-specific. Having seen reports of varied estimates of anxiety and depression during COVID in kids, not just only in Canada, but worldwide, I was a bit surprised that our estimates clocked in at only 1 in 10 children who reported they had high or moderate depression or anxiety. Then again, as we have shown, we collected data in Saskatchewan at a time in the pandemic when it was at a relatively low point. And especially during a month, that is in June, we had most of our recruitment happening in that month, when kids were looking forward to summer holidays as well. In contrast, the estimates of global change in overall mental health and life changes were quite high. So that these are shown in the top in the top two bullets. Again, the takeaway here is that your estimates of mental health impact of COVID really depends on the context of the pandemic and how you ask these questions and what time period you're looking at when you're asking those questions of mental health experience. These are the takeaways from our modeling results, the factors that were significantly associated with our mental health outcomes. I will not go over each of the findings here, just to point out a couple of interesting findings. One, that kids from homes with more people at home, meaning actually there were siblings perhaps, were less likely to report anxiety and depression or depression. Sort of surprised me again, but I think when you really think about that, these are kids who might have siblings, and how many people you can keep company with at home, versus perhaps being isolated or perhaps living alone with one child, for example. Screen time and sleep health were two important, and I would say quite robust, variables associated with mental health outcomes. 3 or more hours of recreational screen time associated with worsened mental health, depression, and lower quality of life. In contrast, kids who had good sleep health, 8 hours or more, were less likely to experience depression and more likely to say mental health hadn't changed. Of course, the direction, what caused what, the causal direction is really, we cannot tease that out because these are cross-sectional data. The last slide on the key takeaways here. Remember, 1 out of 4 kids said they needed help for mental health issues. Of these kids, those who turn to those for help for those they knew the most, and that is family and friends, then the therapist and psychologist, and then teacher or counselor, and last family doctor. And we have given the percentages. These are percentages of kids, 1 out of 4 who said they needed help. Last but not least, as our interaction analysis have shown, kids and families from equity-seeking groups, indigenous, person of color, immigrant parent, didn't fare too well with their mental health outcomes. But this was by no means consistent for both boys and girls, for all age groups and family income levels. They were again quite specific, depending on whether it's a girl respondent that you're looking at, or a boy, and so on. And before we finish up, I just want to pause here and just mention that we have a sort of a companion study on using qualitative research methods. We asked the 510 parent caregivers whether they would be interested in being contacted again for further research. 238 people agreed to be contacted. So we have included them in a pool of qualitative respondents. We are aiming to recruit 30 child youth and parent caregiver dyads, 8 to 18 years of age, the same pool, and we have completed 12 interviews for 8 to 11 age group, 12 interviews for 12 to 15. So we came above that 10 that we were targeting to recruit and interview. We are at 3 for the 16 to 18 age group, and we are hoping that we will be able to meet the target of 10 there in that age group. And they represents quite a diverse group of participants, both male and female, geographical location, people with disabilities, etc. And right now we are transcribing these qualitative interviews, coding them, and we'll be looking at this data in relation to the quantitative data as well, at a group level, rather than at a participant level. So with that, I will just like to acknowledge the team who is behind this research. We are here to present it, but there are a lot of people who did very important contributions, and those whose name appear in bold text are the ones who were on our application, and of course others have since joined our team and contributing, whether it is for analysis, including a parent council, including parent and children, who helped us develop the instruments and will help us present and basically disseminate the information that we have here. Tamara, do you want to, I'm going to stop share and maybe go to the gallery view here. Do you want to offer a quick?
Sure, thanks. I know we're running short on time. I'll be quick. Just to expand, I think, on a few of the important points that Nazim already made. We were all surprised, I think, by the what felt like a low prevalence of anxiety and depression or other sort of symptoms of mental illness. And I think, as Nazim mentioned, a few things really impact those data. One is we're really limited in these validated scales in terms of how we can use them. Most of these clinical scales have some type of duration qualifier on them. And so we can really only ask in a validated way about symptoms within those time periods. They're usually 1 to 2 weeks. So it's a very, very narrow snapshot of symptoms. And I think even more narrow than we had initially appreciated back when we were planning this study. None of us could have anticipated how long this pandemic would have drawn on and in what directions it ended up going. So I think that's an important piece. And relatedly, clinically, I think that time of year in the academic calendar also played a huge role. You can almost, you can plot it on a graph ahead of time when child psychiatry work is going to be busy and when it's going to slow down. And it maps really, really well onto the school calendar, which is quite interesting. You know, we know that there's lots of protective factors to mental health for kids to be in school, but it's a complex relationship, and school is also one of the greatest sources of stress for some kids. And so, you know, our work really picks up. Kids tend to be in more distress mid first semester in mid fall, and again mid second semester, sort of around now, and noticeably slows down during summer holidays and school breaks. So I think that is important context to interpret some of those results. I think what is more interesting and probably more in keeping with what we're seeing clinically on the front lines are more of those global measures about overall, since the start of the pandemic, how has life been? How are you coping? So I wanted to mention that. The other piece that I wanted to mention, and you know, you always think you plan the questions and the surveys as carefully as we can. You know, we went through many drafts, but there's always something that you wish you would have done a little bit differently at the end. And I found myself being really curious about some of the help seeking data that we got, and just wanting to find out more about really the quality of the help that these kids were getting. You know, we asked about it in a kind of a binary way. Do you need help? Yes, no. Are you getting it? Yes, no. And I think the reality of that is much more complex in terms of feeling satisfied with the frequency of the help, the format it's coming in. So I think, I mean, that's the point of good research, is it kind of stimulates new questions. So those were just some that we had.
Great. Nazim, any other comments? Or I have a couple of questions, and there's a question in the chat. I know we're getting close on time, but I think we can ask a couple of questions if that's okay.
Yes, please.
There's a question in the chat, and you touched on this briefly, but you might want to expand a little more. Was there any collection of data if the family had a child or family member with a disability?
I'm trying to recall here. I'm going to look at my my team here. Daniel, you probably you're doing this every day, looking at the data. Tell me whether I don't think we asked disabilities.
We asked.
We asked. Okay. Yeah. So we did ask disability, and we'll be able to include that as a variable. Yeah. Okay. I just want to say just a little bit more. We have so much data, even though it is. I mean, the sample is actually a fairly good size sample for a population of 1 million and 1.1 million. But you know, for about 180,000 or so, 200,000, you know, kids. We have so much data, and the data that we have from a dyad, you know, so from a unit, you know, in a family. So we can look at the data from the perspective of the child as well as the parent, and so that's the next step we'll be taking. I mean, we're happy to report the results to date, but we'll be continuing to analyze this data for some months to come, if not even longer. So,
Nazim, I'm wondering about perhaps some policy or program implications from these findings. Has your team given some thought to that?
So, from our previous work on adult mental health, you know, we have learned that the best way to kind of dive into the implications of research results, policy, practice, advocacy, and so on, is to really talk to people talk to people who are in that space, who are working in that space. Just as we work in the research space, we have data. We have developed some data, and we need to engage policymakers, decision makers, practitioners, program developers, and implementers, and so on, because they usually have lots of solutions. They have, where there's a problem, where there's an issue, they also have solutions. So we want to engage with them and draw out those implications. That being said, from this World Cafe we did in May of last year on adult mental health, 2 or 3 things came up, and I'm just extrapolating it to children and youth. One is that we really need to begin to put our client, our care recipient in the center, and look at that person in a whole way, kind of that wraparound way, and I think this building back better our systems of mental health services, supports, other acute care, and so on. And this, I think if there is something good to come out of COVID-19, if we can use this as a bit of a pause and a reset, and pivot to doing things better, that is what we need to do. So we'll be engaging on that issue, Akila, for some time to come. We have experience doing that. So, and we have built relationships from mental health in Saskatchewan Health Authority all the way to the ministry, and as well as at a regional level. So we are hoping to bring this data to their attention and engage with them, because they are the ones who need to implement at the end. So they need to own their own recommendations rather than actually us giving them recommendations.
Yes.
They need to own developing and implementing those recommendations.
Right, good point. I just want to share something that's in the chat. It would be great if you can add some information around disability in your results and reports to support the efforts of organizations advocating for children and youth with disabilities. So certainly there's a lot of enthusiasm for that data and for you reporting on that. I think we're just at the end of our time together, unless there's any last question. I see a thank you all. I'll just defer to my colleagues if there are any last questions.
None that I can see at the moment.
Great. Okay. Nazim, as always, nobody operates in isolation. There's always a very big and capable team behind the leader and the spokesperson. And I know you've already acknowledged your team, but I just want to thank everybody involved with the important work that you're doing. It's certainly attracting a lot of attention, and we're very excited that you're going on to See You, Hear You 2.0 and additional follow-up research. It's great to hear, and we're very pleased to be a part of the initial round of partnership that made the follow-up funding possible. So thank you for taking the time today to share your results, and we look forward to following this and having you back to report a little bit later on when you have even more tremendous data to share. It's great to hear from you and great to hear about the important work you're doing. And thank you all for your efforts.
And thank you, Akila, and we'll be delighted to come back. It is not a one-off relationship, we think, and so thank you very much, and thanks for your attention. If there are any other comments, feedback, please send it to Akila's team, to Sarah, and we will get it somehow. I mean, this is a bit of a dialogue. I mean, we don't want it to be in one direction. So if there are any comments, any ideas, including any brickbats, I mean, we'll take them and we will do things better. Thank you very much.
And let me just reiterate your point on building back better. If there's ever a time in our country and globally that we're able to do that, this pandemic hopefully has provided that opportunity. And so I echo those remarks, and I think we're all hoping for the same. And last, thank you again to Saskatchewan Health Research Foundation, Patrick and team. Pleasure to partner with you and make this possible. And I hope everybody stays safe, stay in touch. Let's keep collaborating and sharing information. We're all working towards the same end goal, to improve mental health for Canadians. Thank you so very much.
Thank you, everyone.
Thank
Bye-bye.
you.
It's been a pleasure.